juggling the current healthcare system. As you know, we have a lot of challenges as case managers, and this first session, all you need to know about GLP-1s is definitely a hot topic. So looking forward to it. Just as a reminder, hold all the questions until the end, and please put your questions in the Q&A section of the webinar, and do not use the chat session. And it's now my pleasure to introduce Dr. David Dohan. One thing I will mention is I'm a little disappointed we're not on site because I was looking forward to seeing a lot of my former Point 32 health colleagues, and Dave being one of them. Dave started as a part-time as the medical director for pharmacy at Point 32 Health in September 2017, while also working as a primary care physician at Leahy through December of 2023. Prior to that, he had a long tenure as medical director for both Harvard Vanguard Medical Associates and Burlington Medical. From 2010 to 2017, David was the chair of the Department of Medicine at Winchester Hospital. He graduated from UMass Chan Medical School in 1993 and did his training at Dartmouth Hitchcock Hospital in internal medicine. In addition, he has a master's in healthcare management from Harvard T.H. Chan School of Public Health. Welcome, and thank you again so much, Dave, for joining our conference.
Well, great. Thank you so much for having me. Let me share my slides. Great. So you should be seeing my slides. So good morning. My name is Dr. David Dohan. As previously mentioned, I'm the medical director for pharmacy at Point 32 Health, along with the volunteer medical director at the Metro West Free Medical Program. I have no other conflicts of interest. In today's presentation, I hope to cover the full landscape of GLP-1 receptor agonists, from the biological origins, clinical indications, effectiveness, cost implications to society, and issues with prior authorizations. These medications have fundamentally changed how we approach diabetes and especially obesity, and have become increasingly controversial due to the high cost. All the information I'm going to present today is from public sources. Nothing is from Point 32 Health data. So this is just the 6 sections we'll go through, starting from the biology all the way through case management, practical coverage considerations, and future indications. So this slide just situates the GLP-1 conversation, the broader public discourse, and why you guys invited me today. I just took some headlines from some newspaper articles, and these drugs have generated more mainstream media conversation than I remember in recent memory. The only thing I can think of close is Prozac. Back when that came out, it's been driving patient demand, political pressure on payers, and member inquiries to both health plans and especially their providers. So just in terms of these headlines, the first is from the New York Times. Ozempic changed everything. Now comes a hard part. Just talking about how Ozempic was the first really hit for the weight loss demand and just affording it. Boston Globe, the weight loss drug revolution is here. Can anyone afford it? From the Wall Street Journal, Novo Nordisk, Ozempic is so effective, the world can't get enough. If you remember about 2 years ago, there were huge shortages of both Ozempic and Wegovy. People with diabetes couldn't even get their medicines. And last, which I think probably most important, is the coverage from major medical societies, especially New England Journal of Medicine, semaglutide and the cardiovascular outcomes in obesity. This was a landmark trial that just showed that treating obese patients reduced heart disease by 20%, major heart events, which shows that we should be treating obesity as a disease. This guy is one of my favorites. He's a Gila monster. It's a lizard native to the Sonoran Desert. I saw one recently at the Washington Zoo. The Desert is in Arizona, Nevada, Northwest Mexico. And it's the only venomous lizard native to the United States. It delivers its venom through its teeth by chewing, not an injection, like a snake. Um, in this um, lizard caught researchers' attention years ago because it only eats 5 or 6 times a year, but it's able to maintain stable blood glucoses. And in 1992, a researcher named John Eng isolated exendin 4 from the Gila monster saliva and venom. And exendin 4 is a peptide similar to the human GLP-1, but it's far more stable in the bloodstream. It has a half-life of many hours compared to about 2 minutes for the natural GLP-1. And this helps the lizard when it eats and it secretes exendin 4, keeps its blood glucose stable over a long time period. And here I just want to go over the history of timeline. So in 1992, John Eng isolated exendin 4, as we mentioned. In 2005, the first commercial product was released, Exendide Byetta. As you can see, very similar to Exendin. And it was the first GLP-1 receptor agonist approved by the FDA for diabetes. Its half-life was a good deal longer, but still was a twice-a-day shot. So it was not easy to give. And the real modern era of GLP-1 started in 2017 with the release of Ozempic for diabetes. And in 2021, Wegovy was FDA approved for weight loss. And then tirzepatide, which is Mounjaro and Zepbound, came out a few years later. And we've had the huge demand since then. So just wanted to go over how GLP-1s work. GLP-1 stands for glucagon-like peptide. It's naturally released in the gut after we eat. And the pharmacological GLP-1 receptor agonist mimics the human GLP-1, but resists enzymatic degradation by DPP-4. Januvia is a DPP-4 inhibitor. And just as a side note, you shouldn't be using the DPP-4 inhibitors with a GLP-1 because it doesn't add anything based on this mechanism. How does it work? So in the pancreas, GLP-1 causes increased insulin secretion, but it's glucose dependent. And that's very important because it means you cannot get hypoglycemia from a GLP-1 when it's used alone. In addition, it decreases glucagon release from alpha cells in the pancreas and helps survival of the beta cells. And then in the liver, the glucagon decreased release helps decrease release of glucose from the liver, and thus less of a bolus of sugar gain released from the liver, and also decreases fat synthesis and lipid accumulation. In the stomach, it decreases gastric emptying rate, prolongs post-meal fullness, and decreases the rate of nutrient absorption, especially sugar, because the gut's going slower, therefore less of a glucose spike. Finally, in the brain, there are GLP-1 receptors in the brain and throughout the body, and it works in the brain by decreasing satiety, by activating those nerves, and decrease appetite and food cravings. It modulates the dopamine reward circuitry, therefore decreasing the desire to eat and possibly addictive behavior, which we'll talk about a little later. Um, I wanted to just show you all the FDA-approved GLP-1 receptor agonists that are available today. The manufacturers, largely for marketing reasons, have released the same compound with different brand names in FDA indications for diabetes and obesity. But these are exactly the same medicine. I'm sure coming off the same manufacturing line. There's no clinical difference. So as we mentioned first, we have Ozempic, which is semaglutide made by Novo Nordisk, and it's approved for diabetes and also has supplemental indications for cardiovascular risk reduction in diabetics and chronic kidney disease reduction in diabetics. And it's given once a week. Its counterpart, Wegovy, same medicine made by Novo Nordisk, is FDA approved for obesity and also for what's called MACE for cardiovascular events in obese folks, and MASH for liver disease. And we'll talk about that a little later. The third one, semaglutide product, is Rybelsus Wegovy. It's a daily oral medicine. Rybelsus is approved for diabetes. And just recently, to make things confusing, Ozempic is going to be available as an oral tablet approved for diabetes. Wegovy is the name for the obesity oral tablet. And it's the same medicine. The absorption is very poor, so it's a higher dose. They recently reformulated this product, and the Rybelsus is no longer going to be available, and it's going to be called Ozempic for diabetes. And unfortunately, titration is not the same. They're different, so you do have to be careful when we switch people over from Rybelsus to Ozempic. And that's just happening now in the US. It happened in Europe probably about 6 or 8 months ago, and there were some lawsuits around that. Next is Mounjaro, which is tirzepatide from Eli Lilly. It's also a weekly sub-Q for diabetes, is its only FDA-approved indication. And it's a GLP-1 GIP dual mechanism of action. And GIP is very similar to GLP. It does have the advantage that the GIP receptors in the brain decrease nausea, and the GLP-1s, the biggest side effect is nausea. So we do see less nausea with this medicine and superior weight loss, hemoglobin A1C reduction. Zepbound is also from Eli Lilly, same compound, tirzepatide, and FDA approved for obesity. It's the most effective agent for obesity and has a supplemental indication for obstructive sleep apnea in obese patients. Some less used products are Trulicity, also from Eli Lilly for type 2 diabetes. Victoza, which is liraglutide from Novo Nordisk for type 2 diabetes, but this has to be given every day as a sub-Q injection. So its popularity has greatly decreased. Saxenda, same medicine from Novo Nordisk, liraglutide. And this was the first FDA-approved medicine for obesity, but due to its less effectiveness, daily use become much less common. The newest medicine is called Foundayo, or for Gliberon. And this is an oral medicine that was just FDA approved earlier this month. It's from Eli Lilly. It's given as a daily pill. And it's a first non-peptide oral GLP-1. And a peptide, when it gets into the stomach, gets degraded by the stomach acid and very hard to absorb. Because this is a non-peptide, the absorption is much better. And so there's no dietary restrictions around taking this medicine, which I think will become a huge plus for this drug. A diabetic version of this will be forthcoming probably in the next 6 to 9 months. One thing you'll notice on this is that Byetta, the original GLP-1, is not on this slide. And that's because it was discontinued by its manufacturer in 2024 because of decreased demand. As I mentioned before, it was twice a day daily dosing. So this slide is from the CDC showing the increase in the average American weight over the past 60 years. And as our weight's gone up, it's driving the demand for GLP-1s for both diabetes and obesity. So an estimated 41.5% of US adults aged 20 and older were obese in 2020. That's a BMI of greater than 30 compared to 15% in 1975 and 30% in 2000. And of that 41.5%, 9% were morbidly obese, BMI of greater than 40. Another 31% are overweight, which is BMI of 25 to 30. So we're only talking 30% of American adults having a normal BMI. And I would just mention, I get occasional patient worried that they're too thin and their actual BMI is in the normal range. It's just the rest of us, myself included, are too large. This slide shows the dramatic increase in diagnosis of diabetes that correlates to the previous slide's increase in obesity. So in 1984, 5.8 million Americans were diagnosed with diabetes, which was 2.5% of the population. By 2022, that number had increased to 37 million, or 11% of the population, which is 6.4-fold increase. And when you include prediabetes, which is 133 million Americans, almost 1 in 2 adult Americans have a glucose problem. And as you can see, the steepest part of the growth was 2000, or since 2004. The ADA, the American Diabetes Association, estimated that there was a $327 billion annual cost, including $237 billion in direct medical costs, $90 billion in reduced productivity. One thing I will mention, though, is some of this increase is probably due to our better detection of diabetes and change in the definition of diabetes, but the trend is still the same. So next, I wanted to talk about how well GLP-1s work for diabetes. In this slide compares hemoglobin A1c reductions from clinical trials at standard doses. So you can see Mounjaro, tirzepatide, had the greatest reduction at 2.3 at the 15 milligrams. And the 10 milligrams was almost as effective at 2.1. And Ozempic was at 2% for the higher dose. Trulicity, as you can see, was down 1.5. And Rybelsus, which is the oral form, is the least effective, but still pretty effective at 1.4. Orforglipron, which has not been FDA approved for diabetes, but I expect it to be in the next 9 months. The initial studies for that show a reduction of about 1.5%, so similar to oral Rybelsus. So these work well, no risk of hypoglycemia. Next, I want to talk about the cost of obesity. In the financial case for why we should be treating obesity. These cost estimates are based on actual and published health economics data. The data is not, I would say, strong in terms of there's a lot of variation depending on who you read, but the trend is all the same. So the per person cost for treating someone per year with a BMI of greater than 35 is 14,200, which is about 3.4% the cost of treating someone who's healthy. And this is mostly related to obesity-related comorbidities, diabetes, hypertension, obstructive sleep apnea. As you can see from this slide, the costs really go up once you hit people with severe obesity, and are minimal increased costs with someone who's overweight or class 1 obese with a BMI of 27 to 30. And we also know by reducing weight, when people have gastric bypass, their costs go down considerably. They don't get to the same cost as someone with a natural BMI, but close to that. So we can predict if we can take someone with severe obesity who costs us $14,000 and get them into the overweight class, that their costs are going to drop not $9,000, but maybe $6,000 or $7,000. So there's a financial case to be made for treating obese patients, but it depends on the cost of the treatment and how obese they are. So how effective are these agents? So as you can see, again, Zepbound is the most effective of all the agents with about a 22% reduction in BMI after 1 year. Wegovy is the second with about 15% reduction. The oral Wegovy, 13.5. Foundayo is about 11%. In Saxenda, the least effective at 8%. As a comparison, diet and exercise alone is 3 to 5%. In all these studies, people were doing diet and exercise as part of the study. In bariatric surgery, the gold standard is 25 to 35%. So you can see all of a sudden medication with Zepbound is almost as effective as bariatric surgery, obviously with a lot less risk. The caveat to all this is weight regain happens very quickly when we stop these medicines. And I'll go through that a little later on. But I will mention, even with bariatric surgery, we see a lot of weight regain over the years. One thing I just wanted to touch base on is dosing schedule for these drugs, because it tends to be a reason why people stop the medicines and have side effects, or don't lose weight, is because they haven't been dosed properly. So titration schedules are critical for tolerability. As I mentioned, nausea and vomiting are common side effects, happen as you increase the dose. So going slow is very important. And as you can see on these dosing schedules, pretty much every month you increase by the next size of the medicine. Wegovy is every month, 0.25, 0.5, 1, 1.7 till you get to the maintenance at about 5 months. Zepbound, this slide has every 1 to 2 months. I would say it's probably more every month, with slowing down to every 2 months for some steps. So this slide has it every up to 9 months get to maintenance. Probably most people do a little quicker. Oral Wegovy is the same thing. The oral Wegovy, very important that you take 30 minutes before your first food or drink of the day. No more than 4 ounces of plain water. Coffee, even coffee will prevent the absorption of this. So it's a difficult medicine to take. And Foundayo also is similar. It's a titration over 6 months, as there's 6 different tablet size. The other thing that I'd like to mention that's important when you speak to patients is a lot of patients don't titrate up. They don't see their provider again, so they just stay at the low dose, and therefore they don't lose weight. And when it comes for a renewal of the medicine, they haven't lost what the insurance company wants them to lose, and therefore they don't get further coverage. So it's important that we keep people going slow but steady on the titration. So as we've talked about, side effects, and this is key. On the left is the side effects with Wegovy, but similar with the other medicines, a little less with the Zepbound, but nausea, most common, 44%, diarrhea, 30%, and abdominal pain can be significant as well. As I mentioned, tends to happen when you increase the dose. For many people, it's more of a transient thing. Once they get established on that dose, it tends to get a good deal better. And when you look at the trials, the discontinuation rate due to side effects is 9% for Ozempic, Wegovy 7 to 14%, Mounjaro 6%, Zepbound 6%. And when they did head-to-head trials with Zepbound versus Wegovy, the side effect profile for the Zepbound is better, less nausea with that. The other thing I will mention is these discontinuation rates due to side effects are from trials. Trials always have much better rates than the real world situation. So I think the real world, it's considerably higher. As we mentioned, following the titration is key, not to skip dose steps, avoiding high fat or spicy foods if someone's having problems with small meals. Staying well hydrated is very key because people do get dehydrated. If someone's having some side effects, staying longer at that same dose. There are some rare serious side effects. One, pancreatitis. Recently in the news has been ischemic optic neuropathy. And there's a black box warning on these medicines, which you hear on the commercials all the time, for thyroid, medullary cancer, and talking about if you've had multiple endocrine neoplasia type 2 or personal or a family history of this, not to take it. From my reading, this is probably more theoretical. It clearly happens in mice. It's unclear if it happens in people. It's incredibly rare cancer, so I certainly would heed it, but it probably scares people more than it needs to. Next, which I think is obviously on top of everyone's minds, the cost of these medicines. So on this, cost is a very difficult thing, as everyone knows in medicine. There's never just one cost, whether it's a colonoscopy, bypass surgery, or in this case, medication, nothing is simple. So I put the list price of these medicines. GoodRx, which, as people know, is a coupon service, which can give very good discounts on generic medicine, much less so on brand name medicine, but this is what a cash paying person would pay. Then I put estimated annual plan costs, and that's what the health insurance pays for these medicines per year. Again, these are from public sources, and it's very variable because each health plan will have a different agreement with manufacturers based on rebates, and so can vary quite widely. The last I have is the direct from manufacturer price. In the direct from manufacturer are programs set up by Eli Lilly and Novo Nordisk, where people can go to the manufacturer with a prescription and pay cash and get a considerable discount on the medication. So for Wegovy, it's $199 for the lowest dose to $349 to the highest dose. Zepbound $299 to $449. And the prices might have changed since I did this slide. It's constantly changing. The other thing that I want to talk about briefly as we're talking about costs is compounded medications. People probably remember a year or so ago being bombarded by commercials for like him, hers, talking about weight loss medicines and that they were considerably cheaper then. And that is because many places were compounding um, these medicines, which was legal because there's a shortage of the medications. When there's a shortage, the FDA does allow compounding to occur. And those costs were $200 to $400 per month for many of them, sometimes even cheaper. But kind of in early 2025, the FDA stopped allowing this to happen because there was no longer any shortage of the medications. So unfortunately, that route for patient has gone away. Um, so this slide is public data from a GIC meeting when they decided to eliminate the coverage of GLP-1s. And as we go through these data, I think you can understand why insurance companies and payers and employers have decided to stop coverage. So this presents utilization data of the group insurance commission from August 2022 through June 2025. On the left is the total that GIC paid for both the diabetes and weight loss medications. As you can see, for weight loss medications, they paid essentially zero back in August 2022, up to $25 million a month by February of 25. And it's a very steep curve up. And whereas for diabetes, it's going up at a much slower rate. And same as you can see with the utilizers. In the utilizers for diabetes, I will note, has gone up even more, but the cost has not increased at the same rate. So back at this time, 3.5% of the GIC membership was receiving coverage for GLP-1s for weight loss, but 27% of Massachusetts adults had obesity. So there was a lot of potential new people who would want GLP-1s, and the projected increase in the GLP-1 spending accounted for a third of the 11.7 premium increase in fiscal year 2026. At the same time, a RAND survey showed that 12% of Americans have tried weight loss medications. 20% of women age 50 to 64 had. And women age 30 to 50 were twice as likely to use as men. Prime Therapeutics, which monitors prescription use, showed 80% of the users were women. 18% had a BMI of 30 to 34%, 16, 35 to 40, 28% above 40, and 38% didn't have a coded BMI, but estimates are about 20 to 30% of the use of these drugs are people with a BMI of less than 30. So that means that about 40 to 50% of the people using these drugs have a BMI of less than 35%. And if you're an employer or a health plan, those are the people who are least likely to benefit with reduction in costs. When you have a BMI of less than 35%, especially less than 30, you really want to target, if you're just thinking of cost savings, people with BMI of greater than 35 or especially above 40. And based on this data, the GIC eliminated coverage for GLP-1s for obesity. This is from a Senate hearing, and the blue line is the total cost of national prescription drug spending, and the other lines are the increase in spending that they projected depending on the uptake of GLP-1s in the obese population. As you can see, if there was 100% uptake, they were projecting 1.4 or $1,400 billion of spending by 2035, compared to no uptake, less than 800 billion. So these are just really scary numbers if you're a policymaker, insurance company, or employer. And over the past year, we've seen many employers and insurance companies eliminate coverage for GLP-1s for weight loss. This includes my employer, Point 32 Health, Harvard Program, and Tufts, and Blue Cross of Massachusetts also eliminate coverage in this calendar year, 2026. A lot of patients still might be getting it either through Point 32 or Blue Cross, because a lot of times the coverage doesn't end until the renewal of the contract. So a lot of the renewals are in June or September, but when those renewals happen, they'll be cut off. A few employers have what we call bought up and have bought extra coverage to cover their patients for GLP-1s, but it's a very small percent. Next, I wanted to get to some clinical implications for care teams. So one, these medicines are definitely responsible, and I'm sure you guys have seen it, for GI-related emissions. They can cause severe nausea, vomiting, resulting in dehydration and need for hospital admissions. Especially they create gastroparesis. If this happens, need to coordinate with their prescriber of stopping the medicine or reducing the dose. And I've had patients who've been admitted, or at least to the ED, and still don't want to reduce their dose because they're so excited about their weight loss. Pre-surgical, I think this is probably a big one for you guys. Can the GLP-1 significantly slow gastric emptying, increasing the risk of aspiration when general anesthesia is induced. So the major societies have recommended holding the agents for a week before elective surgery. And I do know of some surgeons who want them held for 2 weeks if they're doing GI surgery, because these cause gastroparesis and the GI surgery will induce more gastroparesis. And this can be a problem because elective cases might be canceled last minute because patients didn't hold their GLP-1 the week ahead. And if patients get admitted to the hospital, sometimes their surgeries will be delayed if it's not a true emergency, waiting for these to get out of the system. So a person might be sitting around the hospital for a few days, just waiting for the GLP-1s to get out of the system. Then I wanted to talk about medication continuity. There was a study from the VA showing 43% discontinuation rate after 12 months. I liked this study, because it came out of the VA, so probably less financial implications than other studies. And why do people stop the medications? One is side effects. Two, a lot of times people lost a bunch of weight and they're feeling really good about themselves and feel like they don't need the medication anymore. Three, prior authorizations can be a problematic thing. Most plans require a prior authorization after 4 to 6 months. If that doesn't happen, the people end up stopping it. So what happens when people stop these medications? We see weight gain, regain after the GLP-1 discontinuation. About 2/3 of the weight returns after stopping. So for Wegovy, semaglutide, in the step 1 extension trial, after 68 weeks of treatment, people lost 17.3% of their weight. And when they stopped, they regained 11.6% of the weight within a year of stopping. So 2/3 of the benefit went away. In this same trial, they switched patients from the Wegovy to placebo mid-trial. And those people regained 6.9% of their body weight over 48 weeks, while those who continued on the Wegovy lost another 7.9%. So almost a 15% divergence from the people who stayed on the medicine to the people who stopped. And the same is true with Zepbound. 82.5% of the people who stopped that tirzepatide regained at least 25% of their initial weight, half regained 50%, and 1 in 4 regained 75%. And this is happening when they were counseled about continuing lifestyle modifications. So we really need to be treating this as a chronic disease, similar to hypertension, cholesterol, and really want people to continue the medications if at all possible. How do we manage it when people need to transition off GLP-1 therapies, either because of cost issues, medications no longer being covered, or even if it is covered, the copays can be very high, or people just really want to stop, which, as we know, patients do. They don't like being on medicines. So one in JAMA Internal Medicine did have an article on this about doing a tapering approach that they found more effective. So go from weekly to biweekly to monthly, maybe even quarterly, in reducing the dose at the same time. Using alternative obesity medicines like naltrexone, bupropion, phentermine, Topamax. They're much cheaper oral medicine, so people might be more inclined to do that, at least as a tapering. Obviously, you want to combine these things with diet, exercise, lifestyle interventions. Resistance training also can help some, but we should be aware people are going to be stopping these medicines even if we don't want them to. In terms of coverage, very different coverage depending on the indications. So for diabetes, pretty much everyone covers these medications, at least 1 or 2 within the class. So Medicare Part D, it's a standard cover benefit. Medicaid, it's standard cover. Commercial plans, almost, I think everyone covers it. It's possible that some employer plans don't. I haven't seen it, but I could see it if they just decide not to cover GLP-1. Prior authorization now is frequently required for these. It used not to be required when there was no indications for weight loss. Sometimes the prior authorization is what we call step therapy, which is much nicer for both the patient and prescriber. Step therapy, someone brings the prescription to the pharmacy counter. The computer checks and see if you've used a different drug in the past. And if it shows that you've used metformin or maybe Januvia, it will automatically approve you for your GLP-1, like Ozempic, without requiring a prior authorization. Some of the very sophisticated ones can look for a diagnosis of diabetes in the claim system, but often it does require prior authorization. Either the insurance company is no longer doing step therapy because step therapy can be manipulated. So metformin is used for obesity. It does show some weight reduction. So a lot of patients were put on metformin by their weight loss docs for the purpose of weight loss, and then they could get their Ozempic covered on a step therapy because the Ozempic same medicine as Wegovy, and it was covered by their insurance. So more and more insurance companies have required a hard stop with a prior authorization. Usually that prior authorization is asking for proof of diabetes. Might be hemoglobin A1C above 6.5 or fasting blood sugar, but proof that they have diabetes. And even with step therapy, if you're new to the plan, it would revert to prior authorization if the step therapy couldn't be approved. For weight management indications, Medicare Part D specifically cannot cover weight loss indications by law, Social Security Act, although the Trump administration is trying to get insurance companies to cover for weight loss indications for managed care, for Medicare Advantage. I do not think this is going to go anywhere. Um, the Trump administration is trying to say you can get these medicines really cheap and then offer it to your members. Uh, the Medicare Advantage plans will never accept this because then they're going to get sicker patients. As we mentioned, obese patients cost more than slimmer patients. So I doubt that's going to take off, but Trump is pushing it. Medicare does cover it for three indications called MACE, MASH, and sleep apnea. I'll get into that a little later. For Medicaid, most states do not cover this medication for obesity. Massachusetts has been an exception, and we have been covering it here. In February, Mass Health changed the criteria, and I thought in a very good way that they're covering it for people with severe obesity. So BMI greater than 35 or a BMI of 30 with major comorbid illnesses. This way, they're really targeting the most severely obese while controlling their cost. Unfortunately, it appears starting July 1st that Mass Health will not be covering any GLP-1s. Employer plans and commercial insurance plans have greatly cut back on coverage on GLP-1s for obesity. There are still some. A lot of the insurance plans allow an employer to buy up if it's a large group, but most are not doing because of the trends and how much of a premium increase it is. And all of these have prior authorizations, which I'll get into. Um, so this slide gives the typical prior authorization criteria for GLP-1s for obesity. And I first want to just talk about how pharma works. Um, so pharma will go to health insurers and PBMs and say, if you put our drug on your formulary, we will give you a discount. And that discount can be quite big, often 50%. When they say that, they'll also sometimes say, you have to use our criteria for prior authorization. You can't come up with your own criteria, or we'll at least have to approve your criteria. So for obesity medicines, the criteria that pharma decided was basically the same criteria used in the clinical trials. And therefore, pretty much all the prior authorization have looked the same across all insurance companies because pharma has demanded this. So part of it is they do allow physician documentation that the person's working on diet and exercise. Usually doesn't have to be much more than a physician attestation. Sometimes it's a checkbox of what they're doing. Then the BMI needs to be 30 or greater, or a BMI of 27 to 30 with one documented comorbidity, which can be hypertension, elevated cholesterol, obstructed sleep apnea. And that's pretty easy for almost anyone to have. All you need is a cholesterol of 200 or greater. You have dyslipidemia or arthritis. Many people, over the age of 40 at least have some arthritis. And then the renewal criteria is usually between 4 and 6 months later. The provider needs to document a weight loss of at least 5% of their BMI. For some of the Medicaid products, it might be a metabolic benefit. Again, it is important that we're titrating our patients up when they start these medications. Otherwise, they're not going to reach that 5% reduction. Most people, if they titrate the medicine, will have no trouble reaching the 5%. Next, I wanted to talk about Medicare in its approved GLP-1 indications, because this will be a common way of getting patients these medications. For insurance, for commercial insurance, some will also use these indications even if they're not covering GLP-1s, others will not. So for both Blue Cross Massachusetts and Point 32, they have excluded GLP-1s for weight loss, including these indications. Other insurers will cover for these indications, even if they don't cover for weight loss. So the first one is MACE, Major Adverse Cardiac Events. This was a trial of Wegovy. It showed a 20% reduction in obese patients without diabetes in heart events. So people need to document cardiovascular disease, which is a prior MI, stroke, or symptomatic peripheral artery disease. Prior heart stent or CHF does not count. A BMI of 27 or greater, and the renewal is usually weight loss. Second major one for Wegovy is MASH, which is metabolic associated steatohepatitis. It used to be known as NASH, or fatty liver. And typical PA requirements on this is a liver biopsy, which almost no one does, or a non-invasive test confirming the diagnosis of MASH, fibrosis, F2 or F3 required, often a GI consult, in renewals, either repeat testing or weight loss. The third one is for sleep apnea, which Zepbound has an FDA indication. It was shown to reduce obstructive sleep apnea by 63%. And for this, it's a sleep study with an AHI of 15 or greater, BMI of 30 or greater, documented use of CPAP or intolerance. The other thing for some of these, that they require prior use of other medicines for that condition. So MACE, you're going to have to show that you're on a cholesterol-lowering medicine at a minimum. And for MASH, there is another FDA-indicated medication, which some plans might make people step through. Next, I want to talk about some emerging indications that you might be hearing about, and maybe we'll see approved. So the most intriguing for me is alcohol and substance use disorder. As mentioned, there are a lot of dopamine receptors for GLP-1s, and it modulates the dopamine reward pathways and reduce craving, presumably for food, but also there's increasing evidence for drug and alcohol addiction. And I think this one probably has a moderate likelihood of getting approved in the next 3 to 5 years. Chronic kidney disease, it has been shown for Wegovy to reduce chronic kidney disease in people with diabetes, and we can expect it probably does the same in people who are obese. Polycystic ovary disease, we know weight loss improves insulin resistance and hormonal markers. Again, one would expect with the weight loss, this is likely to be approved. Osteoarthritis, weight reduction reduces joint load. And there's some evidence that the GLP-1s work more than just by weight reduction. Parkinson's disease, this might be more of a long shot, but there are GLP-1 receptors in the substantia nigra, so it might have a neuroprotective status. We actually had a member at Point 32 who's a physician who wanted coverage for a GLP-1 because they had Parkinson's disease and had read up, and possibly depression and anxiety. One thing that was on this slide in the past was for Alzheimer's. There was a lot of talk about this might work for Alzheimer's. Some big studies came out showing no benefit, and Novo Nordisk has stopped any further research on that. And again, just talking about future, near term, might be broader Medicare coverage if Trump gets his way. Higher dose Wegovy was actually already approved about 2 weeks ago, so makes it maybe a little bit more effective. Oral semaglutide, how much these new oral medicine expand the market into demand, I think is actually going to be tremendous for Foundayo because it's just popping a pill. You can take it with anything else. I think this is going to be a very big hit and really drive demand. I don't think the oral semaglutide is going to be very successful given the food restrictions. Medium term, there are what we call triple agonists coming out with GLP-1, GIP, glucagon that appear even more effective. Maybe Medicaid gets coverage, expanded indications, liraglutide, which is Victoza, patents expire. So that might make things price go down. Long term, I expect these drugs to become more like statins when they truly get cheap, though we will be using them a lot more. That might be quite a ways out. And I'm hopeful that we also might see approval, as I mentioned, for addiction indications. So again, just some key takeaways. These are transformative medications, especially for obesity. We've never had anything very effective prior. The cost is just a key barrier to this. Unfortunately, the marketplace, for at least the commercial, has gone really to cash paying only. And I think coverage through plans is only going to get worse. Might get a little bit better on the public plan side, Medicare and Medicaid, depending on Trump. We need to watch out for side effects from these medicines. In the field is changing and hopefully for the better. So thank you for your time and happy to answer any questions.
Thank you so much. There are a few questions in the chat, so I'll read them. And this was great and very informative. So a lot of thank yous for the presentation, but can you expand on your BMI point?
So the BMI point is that people who weigh the most benefit the most from these drugs, both health-wise and reduction in cost. And unfortunately, a lot of these drugs aren't going to the people with very high BMIs. They're going to people with BMIs of less than 35, a lot, less than 30. So we're not seeing the true health advantages when people with those BMIs are getting access to the drugs. I think there's a lot of more cosmetic driven by social media. And if we were purely treating this as a medical thing, we would really be targeting the very high BMIs where we see the most medical benefit.
Okay. And then are there major health crisis complications as a side effect to injectable GLP-1s? Someone is aware of someone who became septic and got kidney stones. So could you expand on that a little bit?
So kidney stones are definitely could be a potential side effect because of dehydration with these medicine. The nausea vomiting can be significant for people. The sepsis, I don't see how that would be directly correlated. But always a possibility. All these medicines, as people know, we do see some weird things. I think the biggest one is pancreatitis being one. The eye does seem quite real, but very low risk. And for the most part, I say these drugs are pretty safe once we get past the nausea, dehydration part in the gastroparesis.
I just thought to separately on this, anything related to the suicide? I know that came out in a few things related to increased tendency for that as well.
Yeah, I've seen things. I've never seen anything that's a good study that really shows it.
Okay,
Whether we'll see more, again, we do know it affects the brain. There's clearly a lot of
right.
receptors for GLP-1 in the brain, so could there be, there could be, um, and I don't think it would be a reason not to use these medicines by any means, but like everything, we need to monitor people. We need to get them in the office, one, to titrate them up, to see how they're doing, discuss all the side effects that they might be having, how to overcome them, and to be monitored for something like that because, you know, any it definitely with all the brain receptors, there definitely could be some people who might become more suicidal. Wouldn't totally shock me, but I haven't seen a great study on that.
Okay, thank you. This is related to the first question about the greatest current cost is from patients with lower BMI. So why wouldn't insurance companies limit starting the drugs for those with higher BMI and
Uh,
greatest chance of cardiovascular benefit instead of discontinuing coverage altogether?
yeah, this is pharma. So as I mentioned, we get rebates from pharmaceutical companies, which are in the range of about 50%. So as a health plan, if we go, hey, we just want to limit this to BMIs of 35, which Mass Health did in February, Pharma will go, yeah, you can do that, but we're not going to give you any rebate. Therefore, instead of paying, let's say, $500 a month, it's going to cost us $1,000 a month. Therefore, any savings by um, limiting to the people with most need disappears, and there's no reason to do it because we're not saving any money. Um, Mass Health did it, and there's a insurance plan. Blue Cross of Southern California has done it. And Blue Cross of Southern California, a couple of years ago, basically said, we're not doing any rebates with pharma. And they have a whole different model, of which I congratulate them because the rebates really drive some things that don't make sense. A lot of people compare the GLP-1 situation in hepatitis C medication. So when hepatitis C medication came out in about 2016, there was similar talk that this was going to bankrupt us. Um, you know, that the cost to treating all these people for hepatitis C, the drug was like $80,000 a year or 100,000, which was just unthinkable at that time. And tons of people had untreated hepatitis C because there was no prior treatment and would all want treatment all at the same time. That would literally bankrupt the insurance companies. And what happened then was pharma allowed us to put very strict criteria on hepatitis C drugs that really weren't in some ways clinically appropriate because other people would benefit, but allowed health insurance to spread the costs out over many years, and costs for these drugs dropped, and they're no longer a big challenge financial impact. But pharma helped health plans by allowing us to do that. With the GLP-1s, pharma said, no, you have to treat everyone the same way. And I think some of this is pharma's thing, where now across the board, almost everyone's saying we're not going to cover it. And pharma has really gone to cash business through these manufacturer direct things, which is much cheaper, as
Okay.
the slide showed.
All right. In the beginning of the presentation, you mentioned the GLP-1 meds have no clinical difference and are produced on the same manufacturing lines. If so, why are there recorded differences in key additional indications, as seen on the medication landscape slide, such as some target cardiac benefits, OSA, etc.?
Yeah.
Is it partly a marketing ploy, or are they targeting effects
No,
truly evidence-based and supported?
no. It's pure marketing. It's the same medicine. They just market under one versus another, and they did the study using one brand name versus the generic. Um, I think, and I don't understand why they did the studies for MACE and MASH using the obesity medicine and not the diabetes medicine. Some of it could be patent issues. So when patent expires, um, if you get a new indication, it extends patent life and things like that. So, but it's marketing and probably something to do with patents as well.
Okay. Any effect on collagen for these drugs?
I don't know.
Okay. I think the question about behavioral health we talked about when we talked about effect on the brain and dopamine receptors and suicide tendencies. How do GLP costs compare to other countries?
Ah, great question. So I did see one thing from Germany, which was about $100 a month for the diabetes versions of these that cost, versus multiple hundreds for here. I was in England with some English friends, and she was paying like $220 for Zepbound a month because, you know, needless to say, NIH does not, or well, the English health system does not cover weight loss. Um, and it's all cash business. And it was about $220 a month versus $350 here.
Okay, thank you. I see a question in the chat. We're going to try to keep the questions in the Q&A, but can you speak to microdosing as a maintenance option? So there are some things around being on this and the private pay range and related to BMI.
Yeah, so JAMA Intermedicine did have an article which I referenced about doing the low dose in basically almost microdosing, going out to quarterly even. I do think there's probably some benefit doing that as you're trying to titrate off or stay on a low dose. I don't think there's any good studies to show that, but I think it's a reasonable approach, especially if it seems to be helping the patient. If they're feeling like they're able to maintain their weight using microdosing, that there's certainly no harm, except for the cost. And likely it probably works, at least for some people.
Okay, thank you. I think that's all the questions in the Q&A and the chat. I'll ask my friends on the committee if they see anything else that I missed. I think we got them all. Oh, hold on, there's something in the chat, I don't know. Yes, and a lot of thank yous, like I said, for comprehensive overview of GLP-1s and a lot of great information for sure that will be useful.
Thank you for having me. And
thank you so much for your presentation and support of the chapter. We really appreciate it.
yeah, if anyone has any questions, they can definitely send me an email.
Okay, sounds great. Thank you.
Have a great day.
Thanks. Okay, so we're a few minutes ahead of schedule, but we're going to continue with our sponsors. And then remember that you need to be present, and we will do a raffle after each of the sponsor presentations that we have. So first, I'd like to introduce our sponsor, Maxim Healthcare, and Charlotte Sweetman, who's the Market Business Development Manager, and Alexandra Bletzer, who's the Market Business Development Manager.